we have 10 patients in the ICU and intubated and 4 extubated, so much better in our ICU. And so we are solved, I think, most of the problems. So just some overview of what we have done, and no conflict of interest, of course. What we learned is that the SARS-CoV-2 was a challenge to be fight with old methods, and mainly mask. This is myself on the train during my travel from Chiavari to Genoa to the hospital. Social distance. This is when Vice Minister of Health just visited us a few days ago. And third, don't touch each other. So this, I think, was the main maneuvers that we kept after the lockdown. We stopped the lockdown since 15 days. Everything is running very well. And since June 3, all region can be connected. So the country is fully open since June 3, but these are very important. And the other 3 T's, I think, extremely important from organizational point of view. When you have after the lockdown, the test, the tracing, and the treat, we hope not to get so much need, but these are the 3 T's to be considered. So COVID-19, just to make very short, I know that also Carmen will talk a little bit less, so I will be quite short, but this is just a very recent review. It appeared very soon. Started as a pneumonia. This is what we believed to be at the beginning. Just then microclots, so just thrombosis. And now I think we have to move towards a concept of multiple organ dysfunction in SARS-CoV-2, and we define it as MOTS-CoV-2. And this, I think, will be discussed by Patricia, and this is the fact that we discovered that this is a multi-organ disease, is a near invader's impact on different organs. And the most important, of course, are the lung, the coagulation, and the kidney, but also all the others can be affected at different levels. So it's a real more complex disease that we thought since February 21, when there was the first patient intubated in Lombardia, and February 29, the first patient intubated in Liguria, in my region. And this is just an example of our ICU. You see this guy is the cardiologist, always with us, Dr. Barbusa, who was very important since the beginning when we found this problem of thromboembolism after 2 days. And then you see the renal support, you see the extracorporeal support. This is, of course, not all patients like this. We treated almost 150 patients in our unit intubated, and 350, almost 400 patients in non-invasive. But this is just to tell you what do we mean. And this is, again, 2 beds with patients attached to the renal support. I think these images give the idea of what is really COVID-2. It's not just a lung disease. And this is the pathophysiology, just to make short, and I know that Carmen will enter into detail on that. So from inflammatory mediators, cytokine storm, and hypercoagulability with different renal failures. So immune cell recruitment and alteration of osteocyte function, and the other side, the hypercoagulation. So these are our data just ongoing to be published, the factors that we found associated with ICU and intubation need. So it was the age, of course, older was the age of the patient. Interleukin-6, we always measured it in these patients, also to target the treatment and the anti-inflammation, and the PO2, FO2 below 100. These were the 3 factors associated with the higher risk of ICU admittance. These are the some anatomopathology findings that we got by cryobiopsy in the people who died within 20 minutes during mechanical ventilation. And the paper is, of course, submitted. And in the early phase, we had really just at the beginning, because then all our patients, they died after many, many days of mechanical ventilation. And we found microthrombo in the pulmonary arteries, some microthrombo in pulmonary arteries, and some inflammation. But in most of patients who died, we found these lesions, as you can see, on the panel A, you see alteration in the alveolar epithelium with fibrosis, and especially type 2 cells and with macrophage in size. And I would like to focus not only on the fibrosis in the other areas, but mainly in the panel F, where you see the red cells. These are red smooth muscle cells in the interstitium, while the black cells are vacuolized epithelial cells. So you see that the fibroblasts are so activated in this process during the disease that they even have a difficulty in their own organization. And this is the different pattern. In the early DAD pattern, you see on the left almost a normal alveoli in the areas with normal aeration on the top of the lung. All these biopsies were performed guided by the CT scan. And you see on the panel B that the epithelial alveoli is completely altered. So it's destroyed, but there is gas inside the alveoli, and the hyaline membrane in red clearly evident. Then when we have a mid pattern, you see in these lower areas of the lung, not consolidated, you see that you have a complete alteration in the alveoli structure and fibrosis. And then when you look at the most severe CT scan alteration, you see in these areas, you see a complete fibrosis of the lung. So fibrosis is the evolution of COVID-19, at least in our experience. Then we also did a lot of samples in the peripheral areas, in these sort of cystic areas, which are likely to be associated with higher amount of pneumothorax and pneumodiacinum. We are looking at the risk factors. And you see here that this is the alveoli are substantially replaced by some mucosidosis, metaplasia, and complete alteration in the lung structure. And this, as you can see here, in the upper part of the lung, we had much early dead phase and much less dead phase, while in the lower part, there was almost most fibrotic areas. So fibrosis is mainly distributed in the dependent and middle part of the lung. What about therapy? I will not discuss that. As you see that there was a lot of therapies where they suggested, not clear data on that. And this is, again, a recent review in which we discuss all of them. I would like just to focus on a few things. These are the difficulties about the role of randomized controlled trial in this setting. And in fact, also all over the world, I think that the quality of the study was extremely low, and the presentation of the data is quite poor. So this is one study on corticosteroids performed, and you see here that the standards are not randomized, but match control in the early corticosteroid administration. You see that there was a reduction in the death, a reduction in the patient requiring mechanical ventilation. So it appears that the corticosteroids given very early were good enough to minimize the progression of the disease. Of course, randomized trials would be needed in the future. And this is again also from our group in PRESS now, and you see that the group on the failure-free survival, it was much higher in the group treated with tolicizumab and methylprednisolone very early. These are very early. So early steroid and tolicizumab as compared to standard of care. And again, the overall survival was much better when we treated patients early with methylprednisolone and tolicizumab, as we did in most of our patients. When we look at the different groups of patients, you see that the combined treatment, tolicizumab and steroid, appears to be better as compared to steroid and tolicizumab alone. However, and this is another study in PRESS from our team, this is when we gave corticosteroid in the ICU. So we maintained corticosteroid even at the lower dose in corticosteroid in the ICU. There was a progressive increase in the risk to develop a blood systemic infection. And as you can see here, the use of methylprednisolone in the ICU, so continuing the use at least after 1 week of methylprednisolone increased 4 times more the risk of SBI, and the combination of tolicizumab and methylprednisolone combined might be associated with increased risk. So our data suggests that anti-inflammatory response very early might be effective, but that the continuance of the treatment in the severe patient might be affected by increased BSI, even if this was not associated with a difference in hospital mortality, ICU mortality, and length of hospital stay. The other problem, as you know, is the gross thrombosis. Again, this is an example of a series, a case series that is going to be published now, and you see here a saddle thrombosis. So this and this thrombosis, as you see at the panel C, was even very peripheral, and this was monitored by the use of Dimer, factor 10 activated. And of course, by doing angiography and CT in this patient. This is just a reminder. This is our protocol for control of coagulation in this patient. I don't enter into detail, but just simply when the dimer increased more than 1,000, we started, of course, treatment with enoxaparin, and when the dimer increased more than 5,000 and progressively we started heparin, and when we have evidence of the echo and angio-CT of pulmonary thrombosis, we started with thrombolysis followed by warfarin, and then switch off on the new anticoagulants in the follow-up. So this is more or less our treatment, and for those of you interested, we can also, of course, share these ideas. This is the Brazilian suggestion and recommendation for the different drugs. I can say that I am agreement in all of them, and especially the use of heparin in those of prophylaxia, as I can see. I see that also the antibacterial in the suspect of infection is very important. I would not suggest to use too much antibiotics in the early phase as preventive, even if we use the ceftaroline, which is an MRSA antigram negative, as prevention, but this might increase for a longer time the risk of superinfection. So the other point is the distribution of densities in the COVID-19. We found more or less 3 phenotypes. Phenotype 1, as you can see here, with the classical COVID-19 phenotype, the mixed in the phenotype 2, and the very severe in the phenotype 3. Really, I believe that these are not really 3 phenotypes, but are just an evolution of the disease. And I can tell you in most of our cases, we had phenotype 2 and mainly phenotype 3, with a reduction in the compliance. And this is another analysis that we are performing. Of course, lung ultrasound is very important, and we used at the bedside as monitoring the evolution of the densities of the lung. As you can see here, different clear patterns can be individualized by the use of lung ecography. I don't want to enter too much into detail on this, because I saw that Carmen and Nemer will discuss that. This is our protocol for non-invasive respiratory treatment in our patient, mainly looking at saturation below 92-95, respiratory rate above or below 28, and the feeling of dyspnea. We used, as you know, CPAP by helmet. This can be used also high flow oxygen nasal therapy or other methods, and we avoided intubation. We have this more than 400 patients in 83% of patients, so we intubated only around 20% of patients who underwent non-invasive respiratory support. And this is an example of patient in the ICU and in the ward with the helmet, but other system, of course, can be used. And then this is the pattern when with the patient we have a PO2 ratio below 150, and so the saturation went below 92, 95, and respiratory rate above 28. We decided in most of the patients to intubate this patient, to start protective ventilation, and with peak between 10 to 15, and according to the clinical situation of the patients. And then when there was the possibility, we prone the patient, but I will show you some data. We always have to evaluate the PCO2 and the PVCO2, and when there was an increase in PCO2 and PO2, probably this was due to a redistribution of perfusion, while if there was a decrease in PCO2 and increase in PO2, this was mainly due to alveolar recruitment, and if there was a decrease in PVCO2, PVCO2. This was likely due to hemodynamic impairment. Another ratio that we are looking for retrospectively, of course, but was within our clinical evaluation was SpO2, FO2, and respiratory rate. The combination of these three factors, which is the ROXY score that clinically we used, was very helpful to identify patients at risk of intubation. This is just to remind that prone position may be associated with improvement in oxygenation with two mechanisms. On the top, you see the densities that are not reversed by prone position. So if you have an increase in oxygenation, but an increase in CO2 or no change in CO2, this is the improvement in oxygenation is likely due to flow diversion and not recruitment. While on the other side, if you have a recruitment of the basal density in prone position that again is associated to an increase in PO2, this is likely associated with a reduction in PCO2, and this is likely due to recruitment. So this is just to remind that if you have an improvement in oxygenation and the PCO2 does not change or increases, the increase in PCO2, the PO2 is likely due to a redistribution of perfusion. If the increase in PO2 is associated with a reduction in PCO2, and likely improvement in compliance, this is much likely to be due to recruitment. So in COVID-19 patients, we found that 40% of our patients improved oxygenation, more than 20% improvement in oxygenation, but only 20% of patients maintained improvement in oxygenation when resupine, and 77% of patients increased PCO2 in volume control. And we, of course, we have to exclude before prone the patient, thrombosis and possible pulmonary thromboembolism. And now we are matching the data for patients who prone or not prone, but there were no major difference in terms of survival. This is prone position during non-invasive ventilation, again from Italy. And you see here that non-invasive ventilation and during prone position during non-invasive ventilation was associated with some improvement in PO2 and SpO2 and reduction in respiratory rate, but this was not maintained in most of patients were repositioned in supine position. And again, you can see here some patients were so-called responders, but then they were back after the repositioning supine. And there were very few patients who were persistent responders. We did a CT scan analysis in patients with supine and prone position, and we found that they improved oxygenation in 90% of the cases during prone position, but we found also a reduction in lung volume, an increase in tissue mass, and a redistribution of perfusion with no major recruitment when patients were positioned in prone position. But then I want to finish this presentation on our data and our initial data, because we collected a lot of CT scan in our patients in different conditions. So I show you just a very initial analysis that will take a longer time. This is our CT scan facilities when we started to do this in the CT perfusion in our hospital. These were the first images of the CT, of course, that we got at the March 1. So we were very much impressed when we look at this. We never, at that time, we did not know anything about COVID-19. And this is the images of the CT perfusion that we get, so we could reconstruct the data from the CT scan and the perfusion that we got from iodine distribution, and we were able to quantify all these distribution in terms of percentage. This is again an example in the distribution and the two pattern of patients, as you can see here, of the distribution of perfusion and the distribution of CT. And so we were able to really pulmonary blood volume. The pulmonary blood volume, we could measure the pulmonary blood volume, which is associated with perfusion, and we were able to measure the hypoperfused percentage because below 0, so if there was no iodine, of course, this means that there was no pattern in terms of perfusion. And these are different CT scans, you know that. So we have very sick patients. Almost this was the pattern that we discovered in the ICU. We did not have a patient with so-called phenotype 1 or phenotype L. And what we found also was a further progression of the disease in some patients. As you can see here, we have another study looking at the early and late phase of the disease likely to develop fibrotic alteration. And this is our data. So just to the first sample of patients, this is all patients, dead patients, and patient discharged from the ICU in the lung tissue distribution, pulmonary gas volume, and pulmonary blood volume. And these are separated from blue in hyper-aerated tissue, which is not much. This was taken at PIP 8. Then we have, of course, different pressure, but this is a PIP 8. Normally aerated tissue in green, poorly aerated tissue in yellow, and red in non-aerated tissue. In the dash area, you have the percentage with perfusion defect. So the areas of the lung in the different compartments and not perfused. So first of all, you can see that there was a lower amount of aerated tissue. You see less amount in green as compared to survivors. So the patient who did not survive had much less aeration as compared to non-survivors. And the total lung mass was half a kilo higher than the patient who survived. So 1 kilo and 600 grams in the non-survivors and 1 kilo in the survivors. The second point is that so the total lung mass was higher in non-survivors. So then you can see here that there was a more non-hypoperfused lung. You see in the dashed areas, in the poorly aerated tissue and in the non-aerated tissue compared to survivors. So these areas were less perfused as compared to the survivors. So means that we don't know if this is due to thrombosis, if it is due to the full fibrosis, as I told you. I think it's not thrombosis because the patient who died, I show you our sample at the cryobiopsy, there was no blood there. Almost these areas in the patient who died were completely fibrotic, disrupting all the architecture of the alveoli and the capillaries. And so then you can see also the amount of blood volume. There was more blood volume in the people who died in the poorly aerated tissue. So this is likely that these patients have a more perfusion in the area of poorly aeration. That is likely also to explain the lower PO2 in these patients, together to some amount of shunt, which was blunted by the fact that there was higher amount of hypoperfusion in the non-aerated areas. And this is the distribution from ventral, middle, and dorsal. We have also the distribution from apex to caudal. And you see here that the distribution of non-aerated tissue increased, of course, from non-dependent to the dependent lung region, and this is expected. This is similar to what in RDS, as well as the reduction in the green areas in the normally aerated tissue, while the poorly aerated tissue remained almost constant. The second message here, you see that the amount of hypoperfused areas was much higher in the dependent lung region, in the dorsal area. As I told you, these areas are likely to be protected by thrombosis or compression or fibrotic evolution in these areas. But interesting, you can see the pulmonary blood volume was non-gravitational. And this is completely different from what was being reported in normal and RDS patients. You see that there was much more blood volume in non-dependent lung areas, while much less blood volume in the dependent lung areas. So this means that we have also not only shunt in the dependent areas, even if they are blunted by hypoperfusion, but we have much more blood in the poorly aerated and well-aerated areas. So we have a low VQ from these areas, which contribute to hypoxia. So we have two mechanisms: low VQ from more blood from poorly aerated and well-aerated, and some blood gas from blood volume, of course, less than expected in non-aerated areas, and this area was fairly protected by hypoperfusion. So this is interesting to have a clear picture, in our opinion, on how is the distribution of blood volume and gas volume and hypoperfusion to explain oxygenation changes in these patients. Further, as you can see here, we found that the D-dimer was correlated with the non-aerated lung mass and the lung mass with perfusion defects, suggesting again that hypoperfusion may be associated with thrombosis. The C-reactive protein was associated with the amount of lung disease, so non-aerated lung mass and lung mass with perfusion. And the PO2 FO2 ratio, you see, was associated with the non-aerated lung mass. We also did several studies on PEEP, and this is not analyzed yet, but just to show you, this is a patient with a moderate disease at different PEEP levels, and you see not much recruitment. So we found not much recruitment with higher PEEP, 16 versus 8 in less severe cases, and also in more severe cases, as you can see here, we did not find a major effect. So overall, our data did not suggest a major recruitment in most of patients with COVID-19. Finally, the fibrosis. This is the one of the fibrosis on these patients after extubation. We did a lot of physiotherapy. We discussed with Nemer at the beginning of the COVID-19, and we have a great effect of physiotherapy. I think that this really was very important, respiratory physiotherapy. And you see in the news, the first on the left, we put on the TV news, national TV news, the first patient extubated. This was our unit, and this was put on the national TV. And this is a patient, I got the permission. He was very, 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 very severe. He was almost near to ECMO. It was not in ECMO. He was almost in the coffin. No, he was in the coffin, and he was resuscitated completely. And now he's in to take the mushrooms or something like that in the wood. So he sent me the images just 2 days ago. I got the permission to show it, and many others. So these are my conclusions. I show you that COVID-19 for sure now is a systemic complex disease. Now we call MOTS. COVID-19. The first bullet has 3 bullets, in my opinion. The first bullet is pneumonia, so hypoxia. If it does not kill you with hypoxia, it can kill you with a second bullet, so with the coagulation, with thrombosis and hemorrhage, that has to be controlled. And then if it's not able to kill you, you can have the third bullet, which is fibrosis. Our data suggests that there are 3 treatments, very early anti-inflammatory treatment, anticoagulation with enoxaparin or more aggressive, and protective respiratory support, and of course we hope for vaccination. What we learned from CT scan and COVID-19 at the moment, of course, we have a lot of analysis ongoing on nitric oxide, effect of PEEP, and many others, the evolution of the disease, the inhomogeneous pattern of aeration and volume distribution and perfusion defects. There was a pulmonary morphological pattern, blood volume, pathological defects were interestingly very much linked with clinical outcome, inflammatory and thrombophilia markers. Higher PEEP in our series at the moment, then we will look at who patients responded, who patients did not respond, and was not anyway associated with a major recruitment, so the improvement in oxygenation was mainly due to redistribution of perfusion. Prone position was not associated with a major recruitment, but mainly with redistribution of perfusion. And we believe that lung imaging techniques, lung ultrasound at the bedside, but most important is CT and CT perfusion. I think it's the first time that we used so extensively CT perfusion, and I think we have to use after COVID-19 to come back to RDS, conventional patients. For the therapeutic assessment of COVID-19 patient, I can tell you that 3 patients with pneumonia, classical pneumonia, we did CT perfusion, and there was more perfusion in the non-aerated area, so completely different pattern compared to COVID-19. So CT perfusion, I think, will be extremely important in the next future to better understand the pathophysiology of RDS and COVID-19 pneumonia. Thank you so much, guys.
Muito bem.
Okay.
Sergio.
Oh. Do you hear me?
Yes.
Yes.
Yes. Excellent, Paolo. Very, very good. So good.
Thank you.
Very good. Carmen, do you want to continue?
No, I'm fine, fine.
Você quer que eu fale?
Yes, Carmen.
Ok. Esse aqui era você agora.
It's up to you.
Não? It's ok. Good afternoon. I'm telling you something about the coronavirus SARS-CoV-2. It's a RNA virus. The genetic material stays inside the envelope, and the envelope is very important because the virus can stay at surfaces more than 72 hours, and this is very important for the contamination. And the virus has spikes of glycoprotein that express outside the envelope, and the virus infects the humans through these spikes. The coronavirus has 6 species that can cause human disease. Four species that the people have mild pulmonary respiratory infection, and nowadays the people that studies the coronavirus, they think that if you had an infection with these other 4 species, you can have defense against the coronavirus. You can't capture in the IgG because the IgG is specific for the SARS-CoV-2. That's why some people do not infect with the coronavirus SARS-CoV-2. That's 2 SARS-CoV-1 and MERS that we had in the past pandemics. And now, since December 19, we have the coronavirus SARS-CoV-2 that caused the disease COVID-19. And the problem with this virus that the virus is very effective, and the RO, that R0, RO, that is the number of infected people. For example, one person passed the virus to 2 other people. That's why the infection spread around the world so quick. The SARS-CoV-2 has this glycoprotein spike in its surface, and this is the spike connected to the ACH2 receptors that is angiotensin, the medication that can take for hypertension, and it's polymorphic, and that this expresses in the surface of the cells, the respiratory epithelium, and that's why you have different expressions of the disease among people. And the people that study this think that these polymorphisms of the ACH2 receptors, that's why hypertensive or hypertension people it's more suitable for the disease. The polymorphisms of the ACH2 receptor is present in the surface of the epithelial cell. Hypertensive people that are hypertensive achieve more the disease than other people. The importance of the infection of SARS-CoV-2, we have to know that 80 to 85% of the cases are very mild. The people have fever, myalgia, but they stay well. But these people can infect other people. So you have to take care with these people that has only mild, some fever. 85% are very mild, but they can spread the disease to other people. So you have to test these people that are asymptomatic or with mild disease, that they are the people that are infecting each other. 15 to 20% of these patients have the more severe form of the disease with interstitial pneumonia and necessity of O2. And only 5% of the infected people have to be intubated and mechanical ventilated. So only 5%, but we have a lot of people infected. That's why we have our ICUs with a lot of people. Here in São Paulo, more than 80% of the ICUs are with only COVID patients, COVID-19 patients, and all intubated people in our hospitals, a lot. The global mortality is around 6 to 8%. Here in Brazil, yesterday I made the calculations. We have 6.1% of mortality in the total. And the problem is the intubated mechanical ventilated people that around the world we have estimated from 20% to 80%. So these people can die with respiratory failure and mechanically ventilated. So we have to take care with these people that will die, but these people, this 8% will infected all the other people. We have to take care with them. 85% with the mild cases, you have to, these people have to be at home. They have to be isolated for 14 days in order to not infect the other people. So these people have to be isolated 14 days, and you have to hydrate these people, analgesics for myalgia, and be at home because you can infect the other people. These people have, if you get a hemogram of them, they have low lymphocytes, high DLL, as a mark of the, if you want to take some laboratory exams for them. What is important that the people that evolves with respiratory failure, this will happen 5 to 7 days after the beginning of the symptoms. So some people go to the PS with the beginning of the symptom with fever, myalgia, and the doctor say go home, but 5 to 7 days after they started with respiratory symptoms, 15% of this, the total. And if you get laboratory exams from them, you get a high protein C, high the dimer, high ferritin, high interleukin 6, and high fibrinogen. These people can develop ARDS, the atypical ARDS, because we have a lot of microthrombose and inflammatory signs of the disease, and the multiple organ failure. The people of the radiology, at the beginning when you go to the emergency room, they get you a CT scan, a tomography, thoracic tomography, and they are classifying the disease with less than 55% of accommodement, 55 to 50%, and more than 50%. And we are deciding where the people goes, if they go to the ward or to the ICU, to the intermediary care, joint the CT scan findings with the oxygen requirement and the laboratory exams. That's how we can decide where people to go inside our hospital. The studies about the COVID-19, people that gave contrast, IV contrast to these people, started to detect embolism and thrombose in these people, as Professor Pelosi told us before me. And a lot of autopsy examinations found thrombosis in the pulmonary arteries and in the lower limbs. So we have to take care about complications as pulmonary embolism and thrombosis. And nowadays, people are thinking about COVID-2 disease, COVID-19 disease as a microthrombosis because the virus enters the alveolar space. The tisular factor is activated, and you can have fibrin and microthrombosis inside the alveolar wall and inside the capillaries, complicating the disease. So we have a lot of, the virus can enter the respiratory epithelium, activates the macrophages and the monocytes, and you have a lot of storm of cytokines, especially in the level 6. And this storm of cytokines will activate the thrombosis and the inflammatory cells, and you have EARDS and multiple organ failures. And people that study the disease are investigating a lot of possible medication to block the virus, antivirals at the initial stage, and the anti-inflammatory agents at the in this phase of storm of cytokines, and even revalescent, the plasma of convalescent people, and even stem cell therapy with mesenchymal cells. Some doctors are testing the mesenchymal cell therapy in the more severe case. Even ECMO you can try in the more severe case. So you have the symptoms that can be mild or severe, the pulmonary accompanyment, the blood tests, and the diagnosis is made by the real-time PCR at the oropharyngeal and the nasal material, or you can do the serology with the IgM, ELISA. You can detect the people that are in the acute phase of the disease. The timeline of coronavirus insects is the beginning or onset of symptoms, and then 7 days after you can develop the respiratory failure and intensive care admission. So you have to take care 5 to 7 days after the beginning of the symptoms, that if you start to have dyspnea or the saturation, you have to go to the hospital in order to take a thoracic CT scan and to be evaluated with a doctor, and laboratory exams to study your disease or how you react to the SARS-CoV-2 infection. At the beginning, the virus beginning at China, at Wuhan. Tá dando microfonia. Acho que é o microfone do Sérgio. Tá ligado. Oxygen, then you can do non-invasive ventilation with double circuits, but here in Brazil we have a lot of BiPAP machines that only one circuit that you have to take care because a lot of aerosols in the ambient. Even Venturi mask, you have the hose of the Venturi mask. If the people has more than 5 liters of oxygen, you can have a lot of aerosols around the patients. Be careful. And the high flow, so you have to protect with a mask of the patient because you can have aerosols and contamination of the people that are taking care of these patients. The people that are taking care of these patients have to be protected with the IPE, the N19 masks, glasses, and cover your hair, and gloves. This patient had to be ventilated with mechanic protective ventilation, low tidal volume, and the sufficient PEEP to keep the oxygenation. Here in Brazil, you are proning the patient. Even the Professor Pelosi showed us that didn't alter the prognosis, the mortality, but here we are having a very good experience with the, when we prone this patient, they are much better in oxygenation, and you can evolve to the mechanical ventilation and the weaning of the patients. And some patients we are doing ECMO in the more the people that are not older and not have a lot of comorbidities, we are doing ECMO. Some people, but not a lot. The treatment, we have to decrease the viral load, and you have to give the patients immunomodulators as corticosteroids and tocilizumab. We are giving tocilizumab at the people that had very high interleukin-6. We are dosing interleukin-6 and giving tocilizumab to those that are worsening, and we can detect a very high level of interleukin-6. We showed 3 cases, only to our case in now that are admitted to Albert Einstein Hospital, that we have the opportunity to have the CT scan and just to see the practical this patient. This one patient is 75 years old. He started to have fever and coffee and dyspnea, and he was admitted at the hospital at May 24, and he did this thoracic tomography. You can see this very typical ground glass findings that all the COVID-19 patients here in Brazil have this kind of typical expression in the thoracic tomography. And then we put him at the oxygen catheter, but he starts to worse, and his interleukin-6 measured was 3,000. So he was intubated, his X-ray, thoracic X-ray worse, and he was intubated mechanical ventilation with 12 of PEEP and delta pressure control of 10, and he improved only one circuit, but here we have to use this one with EPA filters in the respiratory connection to the ventilation of the virus, and avoid that can infect the people that are taking care of those patients. So you have to take this care, because to decrease the possible contamination of aerosols in the patient room. If you have negative pressure rooms, you can use the non-invasive and the high flow more easily. But these other patients are 82 guy with COPD that he started to cough and have fever, and the SARS-CoV-2 was detected in his nasal swab, the RT-PCR, and he started with oxygen. And in this patient, he was very comfortable in high flow nasal oxygen, but he had to we needed for him FiO2 of 70%. But we did high flow and intercalate with no-invasive ventilation, EPAP of 8 and delta pressure of 8 with FiO2 of 40. And when he was in the no-invasive, we can decrease the FiO2. Then when we put this patient in high flow, he needed 7% to saturate 92, 93%. And after 5 days, he improved, and now yesterday, May 30, he was in nasal oxygen with a catheter, 1 liter, and he's very better now. And you could avoid the intubation with high flow intercalated with no invasive ventilation because he was very comfortable without high effort. So when the patient is comfortable without high efforts, we are trying to keep with no invasive measures. When the patient is very dyspneic with high efforts, we intubated and sedated and paralyzed these patients at the beginning. And this last case is a woman, a lady with 86 years old with COPD, but this patient didn't go. She died after days in mechanical ventilation. He has this form of fibrosis after COVID-19. It's important to see that some patients died, and we did all the things. We gave her corticosteroids, convalescent plasma, tocilizumab, protective ventilation, and nothing worked, and she died with pulmonary fibrosis. And so in May 4, the SARS-CoV-2 was detected in her nasal swab, and she was ventilated from 8th of May till 14th of May, and the 16th of May she died with FiO2 of 100%. We tried to increase people, not to increase PEEP, but nothing worked. And she died with 100% of oxygen and a pulmonary fibrosis in the thoracic X-ray. So this is the final message. You have to detect the people that are infected. These people have to be at home to avoid infection for around 14 days. It's very important to isolate these people to try to decrease the contamination of all people, or the other people that are not contaminated yet. Only the people that evolve with dyspnea and desaturation and have to go to the hospital, not these people that has fever and myalgia. They have to stay at home to avoid spread of the disease. Only people with dyspnea that have to go to the hospital in order to have a CT scan or a lung ultrasound to detect the respiratory disease, and they have to be at the hospital. And people that are taking care of these people have to be very protected with gloves, masks, and glasses. And you have to wash our hands a lot of times, and gel alcoholic to avoid the contamination, and try not to I don't know the word, to go around the hospital with the patient a minimum of CT scans or exams outside the ICU, not to try to try to diminish or decrease the spread of this. I call him the crazy virus that cause a lot of disease around the world. Thank you very much. Cadê o Sérgio? Hi, Sérgio. Where are you?
Tá me ouvindo agora?
Yes.
Yeah, yes.
I
Oh,
can
Carmen.
hear you, but I can't see you.
You can see me?
No.
Como é que é? Bruno?
Fala aí, Sérgio.
Ah, foi?
Ainda não. Cadê sua aprendiz?
Agora você apareceu. Silene lá. Oi, Silene.
É.
Tô bem, Silene.
Apareceu, Bruno?
That's in the screen. She helped me a lot in the ICU. She's physiotherapist, and I recovered because of her.
Yes, yes. Excellent physiotherapist.
Tudo bem, Silene?
Não sei, filho, eu tô
Viu,
aparecendo.
Silene? Olha aqui, ó. Tô forte de novo. Doing 1 hour of exercises a day.
Very good, Carmen. Very, very good. Congratulations. Bruno, posso falar?
Não está apresentando seus slides, não, mas pode falar.
Vê aqui, filho.
No share screen.
Faz aqui, fecha.
Respiratorists excellent in COVID-19. A message from Professor Pelosi from Italy. Yes, the physiotherapists here in Brazil are doing a very good work in the recovery of the patients. A lot of rehabilitation because the statistics is 1/3 of the patients are recovered, but a lot of stay with a lot of sequelas and need a lot of rehabilitation to go and get back to work. Agora sim, Sérgio.
Apareceu?
Oi, Sérgio. Coloca F5 aí para aumentar a tela, por favor, no modo apresentação.
Isso aí, bom.
Foi?
Clica de novo, porque às vezes é difícil. Clica de novo.
Foi, perfeito.
Foi, né?
Uhum.
Ok.
Pode começar.
I find this picture and I like a lot, so I try to use. So the situation in Brazil is not under control. We have more than 300,000 people infected. Deaths is more than 28,000. Deaths only in Rio de Janeiro, more than 5,000. São Paulo, more than 7,000. The good news is that there are more than 205 people recovered. The mortality, as we know, is low in the general population with COVID, around 5 to 8%, but mortality on mechanical ventilation is so high. We made a research in Rio de Janeiro, and I find about 47% of mortality in patients with mechanical ventilation in good hospitals and hospitals that offer a public system around 95%. So there's a big difference between private hospitals and public hospitals. So we can observe the ground glass opacities in the great majority of patients, around 57 to 98%. This is the early manifestation, and this situation, we have a good compliance, but the hypoxemia is severe, even with a good compliance. So we see this TC, and we don't observe any consolidation, so we can expect something better, but the oxygenation is poor as a consequence of a perfusion, a poor perfusion. And the late phase, generally after 10 days or 7 days, we can observe more consolidations in the dorsal lung. And in this situation, we have a compliance decreased. So this patient is more difficult to ventilate than the patient that presents only ground glass opacities. The non-invasive ventilation is polemic. So we have to observe and to evaluate with caution these patients. Of course, the patient should be awake and able to protect the airway. I like to do only in double-line ventilator in order to avoid environment contamination. Mm-hmm. I think that I have a double-line ventilator, but I think that I can find hospitals that there's no double-line ventilator as BiPAP, but I prefer double-line ventilator. The ideal is a helmet, as Paolo Pelosi showed, but we don't have helmet in Brazil, so we have to do the no-invasive ventilation with a full face mask. The negative pressure room is recommended, but it's uncommon, at least in Rio de Janeiro. My friend Bruno Guimarães have a negative room in his hospital. We have to use the HEPA filter. This is not a HEPA filter here, but we have to use a filter, and at the expiratory, before the expiratory valve. To do the non-invasive ventilation, we need a respiratory rate in less than 25, FiO2 in less than 50, and to keep oxygen saturation higher than 90 or 92. If the patient is the COPD, we tolerate 90% or 88% severe COPD. We made a trial for 30 minutes. Do not insist if the patients improve the oxygenation and improve the respiratory pattern. Okay, it's successful. We will do intermittent non-invasive ventilation. If the patient fail, of course, intubation is necessary, and don't insist, don't delay the intubation in this situation. With Paolo permission, I will show this picture again. It's a nice picture. I think that everybody in the world liked this picture, Paolo. So it's very, very elucidative. So the phenotype 1, we have observed a ground glass opacities. In this situation, as a compliance could be normal or near normal, we can use tidal volumes around 6 to 8, 4 to 8, but 8 milliliters is not forbidden in this situation because the compliance is better in a great majority of situations. So non-invasive ventilation can be considered in this situation too, but we have a severe hypoxemia as a consequence of a perfusion. So the impaired distribution of the lung perfusion can be the cause of the hypoxemia. I don't see any difference between pressure control ventilation and volume control ventilation in this phenotype. So after that, I want to know the opinion of Paolo and Carmen, but I don't see any difference because the compliance is good. So in this situation, I can find a plateau pressure below than 30 and a dry pressure below than 15 because the compliance is near normal or normal. We have to titrate the PEEP according to the lower driving pressure, and generally we will find a lower PEEP or a moderate PEEP around 8 to 10 or 12 maybe, but 10 is is a number that we have observed a lot. So if the hypoxemia remains, we have to investigate thromboembolic causes. Mm-hmm. And inhaled nitric oxide can be useful to improve the distribution of the lung perfusion. So the nitric oxide can be so important in these patients. Prone position in this phase is not very useful, but of course that we can find patient that presents a good response, but as we don't have any consolidations in these areas, when we prone the patient, we don't have distribution of the infiltrates. But of course, the prone position can improve lung perfusion in this situation too. So the nitric oxide can be useful in this patient. So this is we can observe some pictures in these slides. Here we can observe the circuit of the nitric oxide, and here the circuit of the ventilator. In the phenotype 2, we observe a lower compliance than the phenotype 1. So in this situation, we can observe more atelectasis, more consolidations, and this patient is more critical than the phenotype 1 in the great majority of cases, of course. So atelectasis, the recruitment and consolidations are very, very observed in these situations. High PEEP and the recruitment maneuver can be useful. So we have to open the lung. We try to open the lung because the hypoxemia in this situation can be a mix of poor perfusion and poor ventilation. In this situation, I prefer pressure control ventilation because the plateau pressure is generally higher than 30 and the driving pressure is generally higher than 15 as a consequence of a low compliance. But of course that we find a patient with a plateau pressure lower than 30, okay, no problem in my opinion about pressure control or volume control ventilation. As a good Brazilian intensivist, I prefer pressure control ventilation. Prone and lateral position can recruit non-aerated areas, and the recruitment maneuver can be associated to prone position. So we can prone the patient and to do the recruitment maneuver in prone position. Inhaled nitric oxide generally is less useful, but of course that the evaluation should be individual. We have to consider permissive hypercapnia because the compliance is low, and we try to do a protective ventilation. But in some patients, it's so hard to do the protective ventilation as a consequence of a low compliance. So I think that permissive hypercapnia is important if the pH is higher than 7.20. So I prefer to protect the lung, and I will not worry about PaCO2 higher than 60 if pH is higher than 7.20. So we have to protect the lung and avoid the villi. I want to know the opinions about Paolo and Carmen after that. If non-protective ventilation with more aggressive inspiratory pressures can worsen the fibrosis. I know that the fibrosis is a natural evolution of the disease, but a non-protective ventilation, in my opinion, can promote villi. So villi can worsen the fibrosis in some patients. So if the hypoxemia remains, we have to investigate thromboembolic causes one more time. So in this situation, in these pictures, we can observe a prone position in two different patients. Here in Niterói city and here in Rio de Janeiro city. This is a nice study about my friends, Gustavo Genoa and Carmen, about recruitment maneuver, and I like this theory. So we try to use this protocol in patients with COVID too, but as I don't have impedance, I will stop it at 35 centimeters of water of PEEP. So I try to do something like that, but I stopped it at 35 centimeters of water of PEEP. Just to remember, this is a perfusion of a normal patient without a normal volunteer. So just to remember, this is the supine position. Here we can observe the dorsal lung and here the ventral lung. And as we can observe, the perfusion is so higher in the dorsal lung. But when we prone the patient, we can observe that the perfusion is still higher than the ventral lung. So when we prone the patient, we can improve ventilation in dorsal lung, but the perfusion is still higher in dorsal lung. Just to remember, this is the physiology that sometimes some friends forget about this, but it's important to emphasize one more time. In these, sorry. In this picture, we can observe a impedance. And when we try to titrate PEEP according to the driving pressure, we always observe a lower PEEP, around 10, around 12. And the driving pressure is almost the same, almost the opposite of compliance. As higher the compliance, as lower the driving pressure, of course. So here you can observe a high compliance of these patients, but the best PEEP was not 10 like this compliance are indicating, but around 12 or around 14 centimeters of water. So I prefer to use impedance to titrate PEEP than the driving pressure, but of course that impedance is not available in all of ICUs. So we have to use driving pressure or the best oxygenation. I like to use the best oxygenation because sometimes I use the best driving pressure and the oxygen saturation decrease. So I will prefer to use the PEEP that lead a higher oxygenation, even that I have to increase PEEP in 2 or 4 centimeters of water. And this CT scan, in this impedance tomography, we can observe 10 centimeters of water of PEEP with collapse in this region, like close to the more dorsal lung. So 10 centimeters of water was the best compliance, but 12 and 14, we have a collapse of only 2% or 4%. So in this situation, I will not choose the best compliance, but I will choose the collapse of 2% or 4%. So I will choose 12 or 14 centimeters of water of PEEP. And the phenotype 3 is like moderate to severe ARDS. We will observe a low compliance or a very low compliance. Last week, I saw a patient with 9 milliliter per centimeters of water of compliance. 9, 10, 12, so high. This is in my opinion, it's a terminal lung, like the X-ray that Carmen showed a few minutes ago. It's a terminal lung, a lot of fibrosis, so it's impossible to ventilate because the lung not open, and we cannot open this kind of lung, so it's very difficult. And the prognosis is so poor, the mortality is so high in this situation. So we prefer pressure control ventilation in this situation. Of course, that with a low compliance, the plateau pressure is higher than 30 and the driving pressure is higher than 15. This is a dream. In this situation, this is a dream. Plateau pressure lower than 30 and driving pressure lower than 15, it's a dream. It's almost impossible in this situation. So we have to titrate PEEP according to the lower driving pressure or according to the impedance. I don't like very much PEEP table, but of course the PEEP table is practical. We have to remember that patients that present hypoxemia as a consequence of perfusion, poor perfusion, if we adopt PEEP table 100% of oxygen in and put 24 centimeters of water of PEEP, the patient will decrease your oxygenation. So PEEP table, for me, in my opinion, is not a bad option in patients with COVID if you have a patient with a poor perfusion and 100% of oxygen. 24 centimeters of water will make a overdistension and will decrease the perfusion. We have to consider one more time permissive hypercapnia with pH is more than 7.20. Recruitment maneuver, prone position, and ECMO should be considered. I will remember. I will try to remember after the presentation to know the opinion of Pelosi and Carmen about ECMO in this situation. We have to consider ultra-protective ventilation with tidal volume lower than 5 or 4 or maybe 3 in order to protect the lung, because the compliance is very low. So one more time, protect the lung and avoid VILI. Fibrosis can be observed in these patients, and hypoxemia is so frequent in this situation. If hypoxemia remains, investigate one more time thromboembolic causes. This is a picture of my friend Bruno Guimarães. And here you can observe the perfusion and the ventilation. So we can observe that there's not perfusion in the ventral lung, and there is not a good ventilation in dorsal lung. So we expect that this patient could improve your VQ ratio after the prone position, but Bruno told me that the oxygenation will not improve it. So this is it's a very interesting picture. Thank you, Bruno, one more time. Here we can observe patients with ECMO. So we have to remember that we have to use ultra-protective ventilation in this situation with low tidal volumes, about 3 to 4. Oh, sorry. This is an interesting study, and so terrible to observe these results, because in New York, it's a very evolution in the city with a big evolution in the medicine. We have observed 88% of mortality of patients that will ventilate it. So in New York City, United States, mortality on mechanical ventilation about 88% is terrible. So we have observed more than 88 in Rio de Janeiro, but in New York was very terrible to observe these results. Amazing. So this is our preliminary data. So thank for my friend Felipe Reis. We can observe in our 107 patients, PaO2 FiO2 ratio around 158, PIP 12, FiO2 around 58, compliance around 30, but we have compliance about 9 or 10 that I told you before, age around 61, more men than women, mortality on mechanical ventilation, I think that it was 77. I have to confirm this data, and if this data is about mortality on mechanical ventilation or in the all population. In the ICU, length of stay was around 9.39. This is not a good result because a lot of patients died. So the ICU length of stay, of course, could be higher than these values in patients that present a survival, of course. This is the purpose of an Australian group that we did this kind of extubation, and I think 2 weeks ago. So we extubate the patient, and immediately after extubation, we put a mask with a filter. So when the patient have cough, we already have a mask and a filter after the mask to avoid environment contamination. This is the Brazilian guidelines for early mobilization. So in this paper, we try to do something different than the other guidelines for early mobilization. So we propose joint mobilizations. We propose functional exercise like proprioceptive neuromuscular facilitations with functional movements like to lead to take something or to put something in the mouth. So we have to observe that patient needs something more functional and not to change the position from dorsal to sit down and to going up. So we have to do something more than only to change the positions. So we try to do something different in our guidelines, and I think that the result was very good. So the physiotherapy is very important, as Paolo and Carmen told us before. So as a physiotherapist, I like so much to do the physiotherapy in patients into the ICU and try to walk with these patients into the ICU. This is a patient with COVID, about 14 days of mechanical ventilation. And this day, I decannulated this patient, and at the same day, I walk with this patient into the ICU, and have a discharge for another floor. Of course, that as we can see, this is not a real short, but my daughter helped me again with this picture here. Okay, so it's okay for me. Let's have a talk. Bruno?
E aí, Sérgio? Se perdeu no slide?
Oi?
Acabou?
Acabou. Foi, hein? Tá todo mundo vendo? Paolo's hearing?
Yes, sir.
Can I ask you some questions, Paolo and Carmen?
Yes.
Of course.
About your experience with ECMO, Paolo and Carmen, what do you think about ECMO patients in the early phase or the late phase? What do you think?
So we did a limited number of ECMOs due to the fact that at the beginning we were also overwhelmed. First of all, we did not know anything about the disease when the first patients, and so we have to learn at the beginning. And I am proud that we have taken this decision, because I think that first of all, and we learned after when we started to do ECMO and a lot of renal support, I showed you some slides showing the real life actually. I think that my thinking is just an evolution in the thinking. Is that if you start very early, when you have a lot of patients with a lot of technology, that you are unsure, the risk is that you become stuck, like in the traffic in Rio de Janeiro or São Paulo, stuck in the traffic, and you cannot treat anymore because you have these patients with this super technology and you don't discharge even after 1 month. And so you have also to combine this with the increasing needs and the increasing number of beds that you have to create. So I think that at the beginning we were very slow, and even others, they started very fast, but then they reduced. So very careful, in my opinion. The first message is that the concept of echoes, extracorporeal organ, but I think that one has to be when there are some bad, because if you attach machine, of course you give all the support to the patient, but you have also to have a clear plan, exit plan, especially in this disease. You showed also, Carmen, some cases, then longer and longer, you have fibrosis, you can give all the drugs that you want. You can be protective as you like, whatever you do, but you die by fibrosis infection. Second concept, our experience for late ECMO, So we did the ECMO in patients that we received, especially in the late phase, from other hospitals. They were in mechanical ventilation for 25 days almost, and we got in our unit and we attached to ECMO. I don't have the final results actually, but I can tell you that the experience was not very good. So a very long time in ECMO and not so great results for this late, because I think that, as I show you, after 25 days, 30 days, if you do not improve, the lung is becoming more and more fibrotic. You have nothing to do. And even if you give immunosuppressors, you are even worse because you facilitate even more infection. So anti-inflammatory, as I show you, I think should be used very early to reach corticoid very early in the early ECMO. Early ECMO, yes, I agree. I like very much your slides on phenotype 1, 2, and 3 and suggestion. More or less is what we did. And so, of course, in individual cases, one can try ECMO. The data are very different, you know, between different centers. Were very bad in some centers. Other centers report better results. I think that we had the two factors. I have no time to show you in the CT scan study. There are 3 factors predicting mortality in the ICU. Age. When Carmen showed the patient 86 with COPD, he's almost dead. You can do whatever you want. Of course, you try everything. I'm not saying that you have not to do, but the probability to survive, very low. Age, Charlson's comorbidity index, so more comorbidities you have, worse is the outcome. And we found also CT. But I think that you have to select the patient for ECMO. Very much selected, because otherwise you just wait. Human resources, technological resources, economical resources.
Mm-hmm.
Carmen?
We have few ECMOs here in São Paulo. I think we have to choose, we select the right patients without fibrosis, because fibrosis, you can put the patient in ECMO, but the lung will not improve. And you have to take care because of coagulation of the system. There are a lot of reports of hypercoagulation in the coagulation of the system. You have to anticoagulate more these patients on ECMO. But if you have a young patient with few comorbidities and you not have signs of fibrosis in the CT scan or X-ray, you can try. If you have the resource, the money and the resource, you can try ECMO and see what happens. But if the patient is very old, a lot of comorbidities, signs of fibrosis in the CT scan or chest X-ray, I think you can do not indicate ECMO. Seeing the patients, I think we have to improve our diagnosis in the patients that are not improving. If the patients have a very high interleukin 6 or a high PCR, we have to investigate more secondary infections, and I think we have to increase the dose of anti-inflammatory, try to increase, double the dose of corticosteroids, and try 2 doses of interleukin, trying to stop the inflammation. And we have to take care and do the ventilation. I think there are a lot of evidence that you not ventilate the patient well, they can have VILI, and you have to try to detect efforts of the patients with inspiratory pause and expiratory pause doing assisted ventilation to see if the patient is trying to ventilate, and high efforts is one thing that we cannot see, but they can perpetuate the VILI and do not improve because of that. So we have to to take care of inspiratory force, secondary infection, progression of inflammation, trying to stop this, and ECMO only in few cases that you can see that the patients still have a prognosis. Because
I can add, I mean, I fully agree with what Carmen said, 100%. And if I can add something, you remember that some people, even very famous, some months ago, they say that in so-called phenotype L or better compliance, that again, we have seen very few patients on that, probably because the other were treated more with non-invasive, as I show you. You can increase the tidal volume. You can allow higher tidal volume and higher pressure. I don't think so. I show you some pathophysiology by the CT scan and biopsy. Even in the normal lung, we found alteration in the epithelial, completely disrupted. You have air, yes. You have more blood flow, I show you. So you have low VQ, so you have more blood, and you have a rupture in the epithelial type 1 and alteration in type 2. So this is not normal lung. It appears normally aerated, but it's not normal lung. Now we are looking also at the gas tissue ratio. And also pathophysiology is not normal. And you have more blood, which is not good if you damage the lung. So I think that the concept of protective ventilation, protective pressure has to be considered independently of the level of compliance and the level of the disease. So I think this is a concept that changed, I mean, from what I showed you and the experience that we got first, and also assisted ventilation. We started as soon as possible, but again, we have to be careful not to, we have to be very patient, because if you start very early, you can even further damage with too much assisted ventilation early. Of course, we have to reduce, why prone is very helpful, we used in many patients. We have always to balance the need of neuromuscular blockade agent, corticosteroids, anti-inflammation, all this kind. But anyway, protective ventilation, I think, has to be always maintained. The lung, even if it appears normal, is not normal.
Paolo, do you consider protective ventilation with a tidal volume up to 6 or to 7 or maybe to 8?
I mean, eventually, if you ever need, you can, I think, not to exceed 25. If you have a normal compliance, I will never exceed 20.
I think
I also think that there are two factors. One is mechanical ventilation that can worsen, and the second is the progression, of course, of the disease that we cannot do anything for that. But if we combine, I think that is not good for the lung.
It's a terrible combination.
For the ballet, but by ourselves.
Sorry, it was my dog. So my friend Bruno Guimarães want to know if you see any difference between PEEP titration according to the best compliance or according to the best driving pressure. Do you see any difference?
The best compliance or best driving pressures is almost the same, but I think there are a lot of difference between ascending PEEP titration, descending PEEP titration. Until nowadays, no one shows that the ascending PEEP titration is better than if you study physiologically. The meaning of descending PEEP titration is more physiological. You can open the lung and try to keep you can gain volume in the hysteresis of the lung. You can gain volume at the same pressure. But no one shows that in terms of survival, the descending PEEP titration is better. So I think because in descending PEEP titration you have to be sure that your lung opened, and the only way to know that is doing CT scan or ultrasound, because with the impedance we can see if you are recruiting the lung, but you can't see in the measurements if the lung are open or not. So I think to work because of our work about recruitment during the CT scan, what you saw in all these CTs, you have to see the lung open and then titrate the ideal PEEP, because you open the lung and then you can keep the lung open. But if you're not sure if your lung open, it's difficult to say that this titration is the best one if you know if you were not sure that your lung opened. I don't know if I explained myself.
I mean, our experience was that, but also, Sergio, when you show the AT, when you say, okay, PEEP 10, we have a sort of atelectasis and so on, but when we got higher PEEP, higher than 10, you had increase in hyperinflation. So you had the reduction in 5-6% in atelectasis, and they were not so much because but we have hyperinflation with AT. When you
but do you know that during the CT scans studies, we saw that when you are increasing the PEEP trying to recruit, there is a phase that you decrease your compliance. There is a
yes.
And then
And then you
open the lung.
Yes. So this is possible.
So I don't know if you start at 25. There's a lot of hyperinflation, but you did not open your lung.
Yes. The question is that what we found that when driving pressure, even when we perform recruitment, because I think that these lungs, especially, or we are in very, very early phase, but mostly after 4 or 5 days, when you get patients from around, there were non-invasive respiratory support before, our patients are lung very sticky. Because my feeling is that when you are going worse, you are progressively developing fibrosis. So most of the thing that we see, so I was impressed by our anatomopathology that was performed late because they died late, that you don't recognize even in more vessels. So the lung structure is completely altered. This may be different in the early phase, of course. But anyway, we set people more or less according to a good compliance and according to a compromise for oxygenation.
Yes.
I think clinical practice to help people in Brazil or around the world that you don't have impedance, you have to try to titrate your people with the lowest driving pressure. It's a good idea. And then you have to take an X-ray and arterial gasometry. And you have to have no very high CO2, and the X-ray must be the basis of the lung open with not a lot of atelectasis and not a lot of hyperinflation. Sometimes you do the X-ray, the X-ray is hyperinflate. You have to have a good gasometry and a good X-ray. If not, you have to try to improve the titration of PEEP and tidal volume. If it's okay, it's okay. But sometimes we don't have a good gasometry and a good X-ray, and we don't do our best to try to improve the thing. If your base is still closed, you have to try to improve the areas of atelectasis, or ask for a bronchoscopy to see if there is a lot of secretion in the lower lobes. Try to change the decubitus to see if you can improve your atelectasis. You have to try to improve, try to detect the problem and think together to improve the scenario.
So in the great majority of cases, I have observed that the